Patients will now be able to choose pharmacies, medical practitioners or hospitals themselves without incurring penalty charges from medical aids. The Council for Medical Schemes has found that medical aids' practice of selecting designated healthcare providers and imposing excessive co-payments is irregular. For more on this, we're joined by Jackie Maimin from the Independent Community Pharmacy Association. So a good day for all independent pharmacies, I believe. Jackie, tell us more about it.
Good morning, Jane. Yes, thank you. A good day for patients, Jane, because anybody who is on a medical aid and needs to get chronic medicines, or what they call PMB chronic medicines, will be used to being told which doctor they can see, which hospital they can go to, and which pharmacy they can go to. In fact, many have to go to courier pharmacy and get their medicines delivered or face co-payments. So I think it really is a win for the medical profession and for the patient.
How was this behavior justified?
Absolutely. So, you know, what was happening previously was, as I was saying, and especially the more vulnerable patients. So we're talking here about our chronic patients or patients with cancer, HIV, or comorbidities on the lower options. You know, if you're on a comprehensive plan on a scheme, you can choose wherever you wish to go. But if you're on a lower option, the schemes are quite dictatorial in that they will tell you where you go, and if you don't go there, you face these punitive co-payments. So what the Council for Medical Schemes has said is that this is an undesirable business practice and has to cease immediately.
Okay, so obviously a win for patients. The pharmacies who are left out of these schemes, I mean, obviously it's a win for them as well.
Absolutely. So previously, and you know, I'm with the Independent Community Pharmacy Association. As independents, we have very little voice when it comes to speaking to these huge medical schemes. So very often we were marginalized, and the same with any independent practitioner, so a GP or a specialist, and the independent hospitals were left out, where schemes would prefer to work with corporate groups. And so, yes, definitely a win for us as well. And I think the most important thing, Jane, is that as your local community pharmacy, patients go there for their acute medicines, their over-the-counter medicines, and yet we don't have sight of their chronic medicines or which ARVs they're on, or if they're on oncology medicines, which medicines they're on. And yet it is our duty to make sure that we advise a patient correctly on any adverse medicine or drug reactions, any contraindications, and yet we never had a full view of all the medicines on. I mean, the crazy thing is that the medical schemes would appoint different carriers for different types of medicines. So if you had cancer and you were HIV positive and you were, for instance, diabetic, you could be receiving those three medicines from three different carriers and then still go to your local pharmacy for your acute prescriptions, your antibiotics or anti-inflammatories, and of course your over-the-counter medicines. Now I ask you, how can anybody without a full view of everything be able to properly advise a patient on any potential medicine reactions?
Yeah, I mean, I can imagine that the relationship between a pharmacist and somebody who comes in regularly is important to get that holistic picture. Why do you think medical aids went this route in the first place? How were they benefiting from it?
So, and I must tell you that the Minister of Health was very supportive in our mission to get this corrected. And what he said to us was that there had to be a law. When the government said to medical schemes, you have to pay in full for all prescribed minimum benefits, the schemes needed something to effectively protect them. And that protection was the ability to form networks, which they call the designated service providers. So a scheme could go out there, negotiate with a network of pharmacies or hospitals or doctors and agree on a rate. So that would be then called the DSP rate. So now the actuaries at the scheme can run their numbers and they know the risk that the scheme is going to be subjected to. And the co-payment, which is written in law, the co-payment was meant to be the difference. So say, for instance, I decide I'm not going to go to your DSP pharmacy. I don't want my medicines coming from a courier. I want to go to my local pharmacist who I've been going to for the last 10 years. So I go there and his rate is higher than the DSP rate. The scheme will only pay the DSP rate. So it was meant to be a co-payment of the amount of the difference between what the DSP is charging and what my pharmacy is charging. And obviously, if my pharmacy matches the DSP rate, there should be no co-payment. Now, anybody out there on a scheme who's had this situation, and there are many because I've seen all the complaints, they will know that even if myself as the little community pharmacy matches the DSP rate, there's a penalty co-payment. And that can vary from 20 to 40, and with some schemes, 100%. So in other words, the scheme is forcing you to go to a certain service provider. Now, all along, we were saying, this just doesn't sound right. Why would you exclude a pharmacy who's agreed to charge a DSP rate? Why would you exclude them? And this is the question we keep asking.
Well, Jackie,
and we
thank
don't
you for
get the answers.
Thank you for sharing this good news. It really is. Thank you.